Can thyroid nodules shrink naturally?
Generally, no.
Are there supplements that can reduce the size of thyroid nodules?
Generally, no. However, there is a supplement, selenium, that in some studies has been shown to be associated, a deficiency associated with growth of thyroid nodules, so potentially could be helpful. So it doesn't take a big nodule to cause some compressive symptoms, we call it. It could be changes in your voice, trouble swallowing, maybe with like more dry food or tougher food. Sometimes people will say they feel like they have pressure in their neck worse when they lay flat, or they might see a bulge in their neck. Usually with thyroid inflammation, or sometimes it runs in families, or sometimes iodine deficiency, the entire thyroid can become enlarged for different reasons.
Hi everyone, welcome to our channel. This is Dr. Chhaya Makhija, and thank you for watching and supporting our mission for right knowledge as well as empowering our patients on the knowledge of prevention. It's my delight and it's my pleasure to welcome Dr. Farah Karipineni, who is an amazing professional, an endocrine surgeon, and of course a great friend and a neighbor. Thank you, Dr. Karipineni, for joining us.
It's my pleasure.
I also wanted to share that Dr. Karipineni is an associate professor at UCSF Fresno, which is Central California, and she's bringing on a very new procedure. So in Central California, as being the first endocrine surgeon here, as well as her passion, other than healthcare, also includes talking about healthcare disparities. She loves patient care, as well as her passion is family, farmers market, biking with them, and being outdoorsy.
Yeah, that's true.
So, Dr. Karipineni, your first question: what is an endocrine surgeon?
Okay, well, so endocrine surgery is really three things. It's the surgery of, glands, but mainly adrenal, thyroid, and parathyroid. So that's the vast majority of what I do. And most of that is thyroid and parathyroid. Most of the thyroid and parathyroid is thyroid. So the vast majority of surgery I do is thyroid and parathyroid, as well as robotic adrenalectomies for adrenal nodules.
Mm-hmm. So that's endocrine glands that Dr. Karipineni is talking about. Our main topic today is thyroid nodules, and we are going to break some myths, help you answer or get to know more about thyroid nodule care, and it's all evidence-based science. So we'll do a rapid-fire question, and you can answer yes, no, it depends, one-liner, and then we dive into thyroid nodules in depth.
Okay.
So the first question is, can thyroid nodules shrink naturally?
Generally, no.
Are there supplements that can reduce the size of thyroid nodules?
Generally, no. However, there is a supplement, selenium, that in some studies has been shown to be associated, a deficiency associated with growth of thyroid nodules, so potentially could be helpful. But generally, no.
Are all thyroid nodules concerning for cancer?
No. The vast majority of thyroid nodules are benign, and more than half of the population has thyroid nodules. So the first thing I would think upon discovering a nodule is not that it's cancer, it's that it most likely isn't cancer.
Great point. Okay, thank you. So now we're going to get into the nuances of thyroid nodules. So in general, thyroid nodules are common, and there's also this age-related factor that as we age, there's a tendency to have or discover thyroid nodules. But once someone has thyroid nodules, either it's an incidental finding or someone actually felt it or the physician felt the nodule, what are the key factors that you would consider if the thyroid nodule needs an intervention, a surgical intervention?
Okay, so the first thing is you need an ultrasound. So if it was discovered on a CT or an MRI, that's an insufficient study. So it needs a formal thyroid ultrasound. And once you have that formal thyroid ultrasound, someone needs to read that ultrasound, the radiologist typically, or you or me. And once that's read, the TIRADS criteria needs to be applied. And I use the TIRADS criteria. It's an evidence-based guideline for determining whether thyroid nodules require any intervention moving forward. And this is in the asymptomatic patient. And so depending on the TIRADS score, it may or may not need a follow-up fine needle aspiration. So some of them will need fine needle aspiration to prove it's not cancer, and others can just be followed annually. And some tiny ones don't even need to be followed at all per the American Thyroid Association guidelines. If they're symptomatic, it's a different story because we're dealing more with symptoms. And sometimes you'll have symptoms plus cancer, and sometimes you'll have symptoms from a benign goiter, a benign thyroid nodule. And so determining which one of those it is will kind of guide whether or not we need the fine needle aspiration, whether or not we're going to need to do surgery, whether or not they're a candidate for radiofrequency ablation.
Where we'll get to also.
Yeah.
So just to summarize, so the patient has to, or the healthcare professional who's either referring the patient for an ultrasound, or say if I'm performing an ultrasound, two things are symptomatic, asymptomatic. Then what is the thyroid nodule characteristics? Look at the TIRADS. So that's American College of Radiology. As well as, there's American Thyroid Association that you talked about. And then you're discussing with the patient about, okay, do you need an intervention? Can this be conservative or wait and watch monitoring? Are you symptomatic? Are you not symptomatic? Say if the patient has thyroid cancer, like the final aspiration is proven thyroid cancer, for example, papillary thyroid cancer. What else do you like to see in a neck ultrasound?
So the one thing I see get missed a lot is after the cancer diagnosis or even a suspicious biopsy, which could be cancer. So after that, you have to follow up with an additional ultrasound, which is a lymph node mapping ultrasound. They call it different things at different places, but the thing you need to know is that cancer metastatic to lymph nodes? And cancer metastasizes first to the lymph nodes in the central neck, where the thyroid is, but ultrasound can't see those lymph nodes. So your surgeon has to look for those and have a high index of suspicion to determine if you have central neck metastasis during surgery. However, we can definitely see very nicely the second place to which thyroid cancer metastasizes, which is the jugular chain lymph nodes here. That's the lateral neck. So we do lymph node mapping here. And you might say, well, why don't we get a CT scan or an MRI of these lymph nodes? The ultrasound is actually much more sensitive to determine abnormal morphology of lymph nodes, and we can't find what we don't look for. So I do often see sometimes where patients have this step skipped because the practitioner doesn't know, or they may even be offered a surgery, the surgery that is an incomplete surgery, because postoperatively you're going to be followed for your thyroid cancer. They're definitely going to look here and here for lymph nodes, and they're going to see it then. And you will already have had your first surgery, and then you'll have to go back. You might have had a hemithyroidectomy, taken half of the thyroid. Whereas if you had lymph node metastasis here, you would have had to have a total thyroidectomy. So it also affects the type of operation. And patients who have lymph nodes here need a total thyroidectomy for sure. They can't have half of their thyroid taken out the way you can if you have an isolated small nodule that has cancer in it. And the surgeon has to go in and clean the lymph nodes behind that side that the cancer was on in the central neck, which is called a central neck dissection.
Sure. Yes. So that's my pet peeve too. It's, because of the ultrasound. So any patient that I see for thyroid nodule, be it benign or if they have a suspicious or even a intermediate grade suspicion, is to do either way for my sake to look at the lymph nodes, both right side and left neck. And for physicians who are say primary care physicians or mid-level providers and referring patients to the radiology or imaging center, and you've had your patient get the final aspiration, any surgeon that I have known would want lymph node mapping. And it's basically like a neck ultrasound. So just for simplifying it, if you're ordering thyroid ultrasound, at the imaging centers, they only cover the thyroid. And if you order thyroid and neck ultrasound, then they'll actually capture the entire neck or the relevant neck lymph nodes on both sides, right and left. Yes, because I see that commonly being missed. Even when I order, for some reason, if I have to order thyroid and neck, only thyroid ultrasound is done.
And that's why it's really nice to have the ability to do it in the office. So that's why I like to have control over my ultrasounds and I do the fine needle aspirations too, because you can ask them to do it. And if it's done incorrectly, then you're going to wait months more to get it done again. And it's very frustrating for the patient. Meanwhile, they're already told they have cancer and they need to be waiting for a surgical date, not for more more ultrasounds or
Mhm.
more workup. And that's why I like your
Mhm.
ultrasound, because you
Mhm.
can quickly see things in the office.
Yeah. The other thing that I really love that that I want to highlight is ultrasound. So, we talk about CT scans and MRI,
Yeah.
but for thyroid and for neck lymphadenopathy,
Mhm.
ultrasound would be a go-getter in terms of the top priority for the
Yeah.
imaging.
And a lot of people don't know that. They think
Mhm.
lesser of ultrasound because
Mhm.
it's not as fancy of a study as
Mhm.
cross-sectional imaging, which is CT or MRI.
Mm.
But when you're looking for the architecture of the lymph node and whether that architecture is preserved or not,
Mm.
it actually has to be very obvious to see it on CT. You
Mhm.
actually have to see like necrosis or like
Mm.
just very enlarged. But on ultrasound, you can see smaller details much more clearly
Mm.
if you know what you're looking for.
Mhm.
And that can make the difference in a recurrence or not, or
Yeah.
doing the right operation at the first surgery or not.
Yeah.
So I think that's important too for patients
Mhm.
to know, that you do want to ask your surgeon how many procedures they've performed,
Mhm.
and be aware of these guidelines, because everything we're talking about here, the lymph node mapping and stuff, that's part of the guidelines.
Right.
And so if we are aware of those guidelines and practicing evidence-based medicine, then nobody should be missing it. But I see it all the time.
Yeah. What are the other non-surgical interventions that we know about today?
Yeah, that's a great question. So first I want to clarify, because a lot of patients think when we talk about, they think I have a thyroid problem, and then we talk about symptoms,
Mhm.
and they think the symptoms are hypothyroid symptoms like hair loss or fatigue, dry skin, weight gain, things like that, which are actually not at all, have nothing to do with thyroid nodule symptoms. So thyroid
Mhm.
nodule symptoms are really related to how you feel in your neck with a nodule taking up space.
Mhm.
There's very little space between your trachea and your carotid. This is where your thyroid lives, right in this spot right here. So there's not a lot of space. So it doesn't take a big nodule to cause some compressive symptoms, we call it. It could be changes in your voice, trouble swallowing, maybe with like more dry food or tougher food. Sometimes people will say they feel like they have pressure in their neck worse when they lay flat,
Mhm.
or they might see a bulge in their neck. So these are the kinds of symptoms that we're talking about that could lead to needing an intervention for a benign nodule.
Mhm.
I would say in my experience, this usually, if there's no thyroid inflammation, thyroiditis, which is not what we're talking about today, if there isn't any of that, it's usually at 2 centimeters or larger. I would
Mhm.
be really dubious about a less than 2 centimeter nodule causing compressive symptoms. So if a
Mhm.
patient has these symptoms and the nodule is not 2 centimeters, I would usually look for some other cause before
Mm.
doing an intervention on that patient. But let's say that patient does have compressive symptoms and it is from this thyroid nodule. Then some non-surgical options would depend on what the nodule looks like. So
Mhm.
if it's a pure cyst, like you look on the ultrasound and it's purely fluid filled or mainly fluid filled, the most effective thing to do is inject it with ethanol, 100% ethanol ablation. You can also inject with polydalcanol because ethanol is very expensive. Not
Mhm.
everybody is going to be able to do that. That's very effective. Radiofrequency ablation is less effective for purely cystic nodules, but for
Mhm.
mixed solid and cystic nodules, and mainly solid nodules with 2 benign biopsies, because we
Mhm.
obviously don't want to ablate something that actually should have surgery. We don't want to miss a cancer.
Mhm.
Those patients can have a radiofrequency ablation. And you don't want to radiofrequency ablate something just because it's large or growing in size. If it's
Uh-huh.
large and growing in size, but it's benign on biopsy, and we're not concerned about the biopsy having missed something, and the patient's not symptomatic at all, there's no reason to radiofrequency ablate it.
Mm.
It's really for the benign symptomatic nodule.
Benign symptomatic nodule and 2 centimeters or larger.
Generally speaking, as a practitioner, I would have a healthy sense of suspicion if someone's got a
Mhm.
1 centimeter nodule and is complaining of the compressive symptoms and saying yes to the things we talked about, because
Mhm.
they're not very specific symptoms.
Mhm.
Other things can cause that, esophageal
Mhm.
disorders. Um, if you say voice changes, it's usually going to be postnasal drip or
Correct.
allergies
Yeah, the
or acid
laryngopharyngeal
reflux.
reflux.
Yes.
Yes,
And
LPR.
so we have to be aware that these aren't very specific symptoms. So people saying yes to it doesn't necessarily mean it's because of your thyroid nodule.
Mhm.
So I would say you correlate with the ultrasound findings. And if it's over 2 centimeters,
Yeah.
especially on the left side, the esophagus lies more towards the left in most people.
Yeah.
So it doesn't have to be quite as big on the left side to be causing symptoms.
Sure. Yeah. So you're the first endocrine surgeon bringing this procedure that's a radiofrequency ablation in Central California.
Yeah.
What does it entail?
The procedure
the
itself.
radiofrequency ablation.
So it's an in-office procedure. It's an 18 gauge needle, so not that much thicker than what you would use for a fine needle aspiration. We use ultrasound guidance, so the patient comes in and lays flat. We do a little bit of lidocaine where we're going to introduce the 18 gauge needle. It only needs to be introduced once. So you're only feeling that poke once and you already got the lidocaine. And then we use ultrasound guidance and we just gently redirect the needle probe to the inside of the thyroid nodule with a healthy edge away from the edge of the nodule because you don't want it to rupture. And then we just kind of gently redirect it throughout the volume of the nodule to reduce the volume. And it doesn't work right away. That usually takes about 20, 30 minutes. So it's not a long procedure. It depends on how big the nodule is. Usually patients don't have discomfort or maybe minimal, but they can also, if they have a driver, get like an Ativan or something to calm them down. If they require that. Some will and some won't. It really depends on the person. I find for my fine needle aspirations, because they're so quick, nobody needs that. But for this, people might because it's more like 20 to 30 minutes. And you won't experience a benefit until usually about 2 or 3 months. So usually we do a 3-month follow-up ultrasound, and by then you can usually see a reduction, but you can't expect a full reduction. Like it's not going to go away entirely, but I would say at least 50% is considered to be a successful radiofrequency ablation because we're trying to treat the symptoms. And so I would counsel patients about that because there are patients who we've kind of turned what is a surgical disease in this benign symptomatic patient into a chronically managed disease. Some people might need more than one radiofrequency ablation. The tissue, since it's not fully dead, those cells which are programmed to do benign growth may over time grow again, and they might need it in the future. So you have to tell patients that as well. And some patients will still be very motivated to want to avoid a scar or avoid general anesthesia, the cost associated with a surgery versus radiofrequency ablation. And for those patients, it would be a favorable option. And for other patients, they would rather take it out and not have the what ifs of what if it grows again? What if I need to? What if it's not shrinking enough to make me really feel better with my symptoms? And those are the discussions with patients. So it's really a full risk benefit alternative discussion.
So absolutely. I love that, the patient physician shared decision making, that the patient feels the most comfortable. Most commonly I have patients inquiring about this procedure is when they're very afraid or there's an anxiety that with mostly with thyroidectomy, the dependence on the long-term thyroid hormone replacement. And that's where I feel like RFA would be a great option for someone who has those concerns.
True. And it's true. It's just, it's really just about discussing the risks and benefits because every one of them is going to have its upside and its downside. And the other thing I didn't mention about radiofrequency ablation that I think people should be aware of, I don't think it's a big problem, but it's just something we need to be aware of, is that the tissue will look different. You won't really be able to apply TIRADS after a radiofrequency ablation. And so for long-term monitoring, every person who gets the ultrasound in the future is going to look back to what it looked like before the radiofrequency ablation, and they won't be able to do that anymore because this is going to be the new baseline. And there are bright areas on there, and brightness can look like calcifications. It can make things look a little more suspicious. And of course, we know there were 2 benign biopsies before we did the radiofrequency ablation, right? So they will still need monitoring, and so patients just need to be aware. I don't think it's a prohibitive thing or a dangerous thing. The literature hasn't shown like a bunch of missed cancers, or cancer arising from radiofrequency treated nodules, but it is just something to be aware of. Is it will look different, and that could pose challenges for practitioners like us trying to ensure moving forward that this nodule is remaining stable because it won't look the same.
So record keeping, guys, and then writing your notes, what procedures you've had, the monitoring, scheduling a follow-up.
And don't forget to mention that you've had the radiofrequency ablation to your ultrasonographer so that they can be aware that these changes are expected.
Those are so important points. Are there, you already commented about it, but any reasons or any contraindications where you would not even discuss the RFA or radiofrequency ablation with the patient as the surgery takes priority?
I think, when surgery would be the priority. Like I would never do a radiofrequency ablation at this point. I know that it's been discussed in tiny cancers and things. I'm not at that point of offering it personally, but I wouldn't do it for anything suspicious. So if a patient had any level of suspicion for malignancy, which I'm talking about Bethesda 3, 4, or 5, or whether or not molecular testing was done on those nodules, and then for the ones that molecular testing was done, if it came back suspicious versus benign, then I wouldn't offer it. The larger nodules or just like a goiter, let's say you had a large goiter and the lobe is large and you're having symptoms, but there's no real nodule to target. I don't think it's indicated in that situation. It's not a conventional use. So that would be another thing where I would say you should probably have surgery.
Can RFA be indicated for someone with lymphadenopathy and papillary thyroid cancer?
No, definitely not. That patient needs not only a thyroidectomy, but a neck dissection and needs post-op radioiodine. So you can't actually do radioactive iodine on a patient with any thyroid tissue at all. I'm not sure everybody understands that or realizes that. That patients with lymph node involvement or extrathyroidal extension, which means the tumor is going into the surrounding tissue, usually skeletal muscle, but it could be anything, it could be esophagus, trachea, or the recurrent laryngeal nerve. Those patients need radioactive iodine. And if you know that up front, then you would never leave any thyroid tissue behind. You wouldn't do a half hemithyroidectomy. You wouldn't take, half of it out. You take the whole thing. And you certainly wouldn't do a radiofrequency ablation because it would leave the whole thyroid tissue behind. And you could never do radioactive iodine, which is the adjunct treatment you need for thyroid cancer that spreads to the lymph nodes.
Yes, yeah, so true. Yes, so a lot of enlightenment here. From the professional. Thyroid cancer or suspicious nodules for thyroid cancer versus benign nodules. Very different approaches, and you want to take the right steps because it's your health. If any patients are really hesitant about any intervention, be it non-invasive like the RFA or even surgery, but they have benign nodules and they're not symptomatic, what key factors that they should be aware of in terms of monitoring, who to follow up, and in the next 3-5 years, or resources that you could suggest?
Yeah. So if you discover that you have thyroid nodules on an ultrasound, then I would, and it's been determined that you don't need any interventions. You're not symptomatic. There's nothing that needs to be biopsied to prove it's not cancer. Then typically what we would do is a yearly ultrasound. And initially that ultrasound is done the following year. So the first ultrasound after that's discovered, I would follow it in the next year. So I would advocate for that as a patient. It would be nice if you could advocate for having it at the same place that you had your previous one, because radiologists will always look at the previous scan to look for any changes. And different scans can look very different. We're looking for different shades of gray on ultrasound. So it's very subtle, and different scans, different ultrasonographers, there's different techniques to doing it. So stay with the same person if possible. And then after that second time that you have it, if it demonstrates stability and nothing's wrong, I usually would do 3 years of just every year. And then we're supposed to do 5 years per the American Thyroid Association or the TIRADS guidelines, right? So then after 3 years, I'm like, okay, I'll do it in 2 years. So we don't have to keep doing it every year. And then after 5 years, I offer the patient to maybe they don't want to follow it anymore. And for the guidelines, if it's stable, their baseline risk, they don't have a family history of thyroid cancer, they haven't had a personal history of radiation, then it's safe to not follow it anymore. And some patients like that, and other patients would want to follow it longer, maybe every 2 years, just to see, because especially the young patients have a lot of life left ahead of them for something potentially to happen. And so I would just be aware of that being the general expected course as a patient. And if you forget about it for a long time and you're like, oh, I was told I had thyroid nodules on this incidental scan on a CT and I never had an ultrasound, then go get an ultrasound, a formal ultrasound. If you had an ultrasound several years ago, maybe just go get another one so that you know that nothing's changed. And always make sure that if you're looking for changes, that you have access to your previous scans. I think all patients should have that themselves, because these days we are all in different networks. And so it's systems, it can't be assumed that we're going to have access to your previous scan. And even if we have access to the previous scan, I would take it a step further and say, if you bring the CD, I usually have patients bring a CD with them.
Same here.
And I almost won't be able to see the patient if I don't have the previous CD, because so much of radiology reporting of thyroid nodules is not TIRADS based. So have your records, and that would be good.
Yes, I so agree with everything that you said about the monitoring. We end up seeing also patients with these tiny cysts, and they're so concerned about 3 millimeters, 4 millimeters, less than a centimeter cystic or mixed cystic nodules. And, the American Thyroid Association has this nice table of all the types of nodules, like the characteristics,
Mhm.
and then grading them into, low suspicion, high suspicion,
Yeah.
intermediate suspicion, or, very, very low suspicion also.
Yeah. And so, like, if you had scattered cysts throughout your thyroid, it doesn't matter if there's 3 or if there's 23. This I wouldn't worry about it at all.
Yeah.
And so the size is not as important as the appearance, and the number of nodules, again, not as important as the appearance of the nodules.
Mm-hmm.
So I agree with you. As
Yeah.
patients, I sometimes describe it, if a patient has a bunch of like tiny things throughout their thyroid and they're like, is that normal or abnormal? And I'm like, well, it's kind of like having freckles. Like I
Mm-hmm.
tell me technically normal skin is clear skin, but
Mm-hmm.
a normal variant is freckles. And so the fact that you have, several cysts scattered throughout your thyroid is
Mm-hmm.
it's kind of like having freckles.
Yeah.
And some freckles become moles.
Yeah.
And those ones we care more about and we monitor
Yes.
those. And then some
Yes.
freckles we don't care about. And so we just let them be.
Yeah. So one last question that it brings, as you're describing this, that as in endocrinology, we end up getting consultations for Graves' disease and hypothyroidism or Hashimoto's thyroiditis, and in these individuals, they, a subset of population will have large thyroid glands, and they're very heterogeneous.
Hmm.
And when they get radiology imaging externally, the heterogeneity is described as multiple nodules.
Hmm.
So, just what you're
Yeah.
holding, or even something like this.
Yeah.
And this, I call this as pseudo-nodular, because
Hmm.
technically
I use
there
that
are no
term. Yeah.
nodules. You do use that term
Yeah.
too? Okay. But if you can share, your expertise, because you see these glands. So just a brief idea of what the difference between, a goiter or an
Hmm.
enlarged thyroid gland versus an actual thyroid nodule.
Yeah. So I would say usually with thyroid inflammation, or sometimes it runs in families, or sometimes
Mm-hmm.
iodine deficiency, the entire thyroid can become enlarged for
Mm-hmm.
different reasons. And you see that as just an enlarged lobe, like the measurements of the lobe will be
Mm-hmm.
larger than they're supposed to be. The thyroid is kind of engorged. Maybe there's signs of inflammation as well, but there's
Mm-hmm.
no discrete nodular area, like so
Mm-hmm.
not an actual nodule. And some of the tissue, like you can see on ultrasound, and you'll see it, when you see it in surgery, because there is an inflammatory process going on in
Mm-hmm.
there will be a patchiness of the tissue. Again, kind of like freckles, like for Hashimoto's disease or for lymphocytic thyroiditis of any kind, Graves'
Mm-hmm.
disease. You might see there's a lymphocytic infiltration. You can see it on ultrasound in patchy areas. And we're, again, looking for shades of gray. So you'll see some gray areas, some normal brightness areas, some more bright areas.
Mm-hmm.
And some radiologists or some ultrasound techs, because they're the ones making the
Right.
measurements, would choose this area and just put markers around it. And then there you go. It's a
Yeah.
nodule. It
Yeah.
becomes a nodule based on that
Yes.
alone.
Yes.
And then they get sent for a referral for that. And then when you look at the tissue, like you and I would look at the ultrasound and look at that and say, I don't actually think it's a nodule. Or you might repeat an ultrasound and it looks different, because
Mm-hmm.
patients with thyroid inflammation can have varying levels of inflammation. So they not uncommonly will have a different appearance if you interpret it, or you're doing a different ultrasound, like let's say 3 months later, even, which you
Mm-hmm.
wouldn't expect a nodule to change in 3 months. But with inflammation, that pseudonodular area would change. And
Mm-hmm.
so these are some, I would say, diagnostic challenges.
Yeah.
And I think it requires of someone who's experienced enough seeing
Mm-hmm.
this to feel confident enough to call something a nodule versus a pseudonodule. And
Mm-hmm.
I actually welcome people saying something's a nodule versus assuming it's nothing
Mm-hmm.
on the outside. And
Mm-hmm.
then for someone like me to be able to confidently say, I don't need to biopsy that,
Mm-hmm.
versus the opposite, which is that you miss something.
Correct. Correct. Yes. What would be an ideal scenario where the healthcare professional, the clinician, is doing like the steps that once they learn, either they are feeling the patient's neck and they have an abnormal thyroid enlargement, or they feel a nodule, or they see that, there was, say, an incidental thyroid nodule discovered on carotid ultrasound. What are the first few steps that they should be doing before they decide to refer to an endocrine surgeon?
That's a great question. I think a formal thyroid ultrasound, it doesn't
Mm-hmm.
even have to be lymph nodes, just a formal thyroid ultrasound. Second thing is, if you do have the need for a fine needle aspiration, make
Mm-hmm.
sure that when you're sending that patient for the biopsy, that it is going to be a fine needle aspiration. And that's the same thing that I find with different radiologists, is that some of them will do a core needle biopsy. There's very few indications for a core needle biopsy in thyroid. Most people are not going to have that situation. I'm talking about giant goiters when you're trying to look at lymphoma of the thyroid or anaplastic cancer. This is the perfect situation for a core. That's 1% or less than 1% of your thyroid nodules. Everybody else needs a fine needle aspiration. And those radiologists that do those, or wherever you're sending the patient, if sending to an endocrinologist, you also want to know that they're going to send it for molecular testing if applicable, which means that you want them to get, at the time of fine needle aspiration, collect a little bit of the sample in case it comes back as indeterminate, so that you can send it for an additional layer of testing. That's called molecular testing. So for patients and primary care doctors, if you really want to make sure that this patient's going to get, not have to repeat any testing, then I would say definitely get the ultrasound done with someone who knows TIRADS, and then make sure if you need a fine needle aspiration, it's actually going to be a fine needle aspiration, and that they know what molecular testing is. There's some places that don't have molecular testing. You know, there's all kinds of issues. So just being aware of that is important for patients, so they can make the best decisions. Or you might want to send your patient out if you don't have molecular testing. You might want to send them out, and they might be very willing to drive somewhere else to go get this test done, so they won't have to get it done twice.
Yes, yeah. You know, this is just for patients, specifically for patients, because yes, the practitioners, clinicians go through a process of paperwork and orders, but the patient is, you know, filled with anxiety, filled with concerns as to what's next. So molecular testing, I completely, would go for it. As a reflex for the patients to get that done. Any last minute parting words of wisdom for healthcare physicians, clinicians, professionals in this field in medicine, as well as patients?
I think probably like the one thing that comes up just for patients is to just know that your thyroid nodules are probably going to be okay. And yes, you may have to get it checked out. You might even need a final aspiration, but most of these nodules are going to be okay. They're not going to be cancer. They may not even grow or require surgery. So the first thing would be to not worry necessarily as a reflex. And then second thing is to understand that it's really common, in fact, most common for your thyroid function to be completely normal with thyroid nodules. So you kind of need to uncouple. Some of us need to uncouple in our brains the idea that we have a thyroid problem. We have a thyroid nodule problem, but our thyroid function is fine. So your thyroid function's okay. And so therefore probably any symptoms on the hypothyroid or hyperthyroid list with a normal TSH probably are not going to be associated. It's very, very rare. And that would be in the setting of thyroiditis, which is a completely separate thing.
Yeah. Thank you. These were all great insights. Thank you so much for joining us.
Thank you for having me. I appreciate it.
Thank you all for watching, and you can hit the like and subscribe. You're going to bring in more education in the realm of health, including rheumatology, endocrinology, as well as the entire health.